So, hello everybody. I hope everyone is well. I'm greetings from Portugal, from Porto, and I'm first of all I would like to thank KLOCKNER with its international department for this kind invitation, and especially to Ramon and to Jose, and as well to International Meetings Company, especially to Mario Ruedas, who was helping me and is providing all the technical support for this live presentation. So first of all, I'm going to share my presentation. Just a second. Okay. So the topic this afternoon that I'm going to present to you and to share with you, it will be focused on bonded restorations in the anterior dentition. And we'll talk mainly focused on the comparison between digital and analogical workflow. And I would like to add that this presentation, I will be glad to answer all your questions. You can write them in the Q&A panel that Zoom platform provides us, or you can, I'm not sure if you can go directly speaking, but if you want, you can interrupt me and or at the end of the presentation, just ask me, please, all the doubts that you have, so we can, between all of us, can learn a little bit more about this topic. Before going straight to the main theme of my presentation, I would like to present myself. First of all, I live in Porto, in Portugal. I don't know if you have had the opportunity to be here, but it's a very nice, romantic place with nice weather. And I'm sure that when all this pandemic crisis finishes, it will be great if you have the chance to come here and spend a couple of days to enjoy our weather, our food, our wines, and our cultural heritage. So here in Porto, we have our private practice. This is our institute. It is the brother of the Barcelona Dental Institute that you might have listened about with the Dr. Roberto Padros. And here we have three main focus on our activity. Of course, we have our daily clinical practice, where we develop all kinds of dental treatments. We also have some clinical and in vitro research combined with other institutions like universities or private companies, in this case like KLOCKNER. And also we have some continuing education programs as we are associated to a local university where I lecture for, I am a professor in the last almost 20 years. It's Fernando Pessoa University, and where we developed some postgraduate programs in the short or in the long term. So as always, I would like to present you some of the people that had some contribution to this work that I'm going to share with you. Because obviously this is not a single person work, but most of all it is a group of people that try to get to a higher level of knowledge and scientific progress. And as you will see, we are trying to adapt ourselves to this new reality, or this new digital way of working. Okay, so the first question is, why are we going into digital? I mean, everybody is crazy about digital tools, digital work, But why is that? Why do we have real advantages in doing these kind of treatments supported by digital tools? As you all know, in restorative dentistry, we have like three main steps during our work. First of all, obviously, all the planning phase, where we are turning from the conventional wax up to the virtual planning way of doing this kind of treatments. Then we will go on to the dental preps in case we are talking about dental supported restorations. And in case of implants, obviously, we will do the surgical phase. And then we'll go straight to the lab clinical workflow, where we are changing a lot, not only in the lab work, but also as well in our clinical steps that we are changing to this new digital reality. So I think we could resume the possible ways of working nowadays concerning how do the planning phase and the creation of the final restoration. So we can do everything conventional. So we will do a conventional wax up, and then we will do a conventional build of our final restorations. For several years, we changed slowly to this kind of workflow where the planning was still full conventional, conventional impressions, plaster models, conventional articulator, conventional wax up. But then the building of the final restorations were more and more based in a CAD/CAM creation in the lab. The next step would be to change this way of planning to the 2D and 3D digital planning. The DST protocol that Christian Coachman presented several years ago changed a little bit the way how we were planning our treatments. And at the beginning, we started only with the anterior dentition, but then we got to the actual reality where we are doing full mouth planning with these kind of tools. And again, we would still build our restorations based on CAD/CAM technology, with or without manual layering of ceramics. And the last way of working, not necessarily the best, could be the full digital workflow, where the only physical and conventional steps that we would take concerning natural tooth was the prep of our teeth, and then the cementation of the final restorations. All the rest was obviously supported by manual hands, but mainly everything was designed with digital tools. So in a case like this, and this is I can say an old case that we treated in Barcelona a few years ago, we did a conventional step, a conventional workflow. This was a patient that we received. She had she was 19 years old, and she was very sad about the aesthetics of her smile. And as you can see, there's some signs of a lack of a good enamel in the outer surface of this teeth. And with a good diagnosis, we could finally conclude that this was a fluorosis problem. In this situation, we could mix this diagnosis with an imperfect amelogenesis. would, in this case, this would limitate a little bit the possibilities of adhesion in this case. But was a case where beneath, under this outer enamel, we had a very good quality enamel. So we did a conventional wax up, and as you can see here, it was very easy wax up because the primary anatomy of this teeth was not so bad. The problem was mainly the color and this brown spots that we could see here, and some cavitation in some of these teeth. So we did a very simple wax up, manual wax up, and of course we tried this with an additive mock-up directly in the mouth using an extent bisacryl composite, and as you can see, there's no big changes between the initial situation to the test mock-up that we did. So if this is our final objective or for our treatment, the next step is obviously guided preparation, as conservative as we could do it. I remind you that in this case, the outer enamel was not so good for adhesion, so we had to go a little bit deep to expose the more sound structure, the more sound enamel. And this is the final preparations, where you can see that we can do it with equigingival margins. We don't have necessarily to go beneath the gingival margin, and we did a conventional impression and then direct provisionals with the same material that we use for the mock-up. So this is just after putting the provisionals, and this is something that you probably might be doing every day in your clinic. So this is not there's nothing new here for you. The way that we built this ceramic feldspathic veneers was based in a very conventional and very artistic, if I may say it, way of building this kind of restorations. This is a refractory model technique, specifically the one-bake technique multi-layer, that our technician, in this case, Mr. Ferran Puigrefagut, built these beautiful restorations. And as you can see, when you're applying this kind of paste of ceramics, that you have to layer several kinds of ceramics, denting layer, enamel layers, incisor layers, it is very difficult to predict the final result, because besides that, you have to over contour the ceramic layers, because with the baking they will contract more or less like 20% of its initial volume. So you might agree that this is not a technique that is suitable for everybody. This kind of layering technique, in my opinion, it is very difficult to achieve such a result without training, lots of work, lots of repetitions, and maybe in some cases you'll never get to this kind of level. I myself cannot imagine how long should I take to achieve this kind of result if I was a lab technician. So this is a very typical case of what nowadays we still use this kind of technique, but with certain kind of cases, and maybe not when we are doing like 10 veneers or 8 veneers, but maybe with this kind of individual features for each one of these tooth, maybe we will use it when we are doing single tooth restorations. As you can see, the thickness of these veneers are very low, like 0.6 millimeters. It could be less if you were talking about a regular case, not this case where we had to prepare a little bit more. And you can see here the optical properties of these veneers and the trying before cementation. And you can compare with our mock-up, where you can see some differences between primary anatomy that we got in the wax-up and that you see here in the final result. It's easy to understand that it's very difficult to achieve exactly the same anatomy that you plan with a conventional wax-up and to translate that to the final restoration when we are doing handmade techniques like this. So it's very easy to get some distortion between the initial planning and the final result because of the nature of each technique, either waxing up or layering ceramics. So this is then we do the conventional cementation protocol. Probably most of you are doing the same protocol as we do with a total etch technique. Since we are in enamel, we use a resin cement or a heated regular resin composite to cement this kind of restorations, and we do a good final polishing as best as we can. And you can see here a couple of weeks after the final cementation and the final result that you can check here, where for economic reasons the patient didn't want more than to the first premolar veneers. So I think it's a natural result, but this is I would say, more or less old-fashioned way of doing it. And old-fashioned doesn't mean it's low quality. It is very high and quality and very difficult to achieve these kind of results, especially when you're not dealing with a technician that has this kind of artistic qualities. So for this, we changed slowly to like a digital manufacturing protocols. So digital started, if I may say, first in the lab, and before then it started in our clinics. I mean, everybody, I think we can agree, was sending conventional impression, conventional occlusal records to the lab, and we still do it. So the lab could transform these conventional records to a digital workflow. So they used a scanner, a desktop scanner to digitalize a conventional impression or a conventional model. And then they would do the digital manufacturing, not always the monolithic restoration, but most of the times the infrastructure, and then layering with conventional feldspathic ceramics. So in a case like this, where we are combining tooth and implant in the same case, you can see here where we have two central incisors to restore. This was a case that we treated again like 7-8 years ago, where we had to combine this implant in the central in the right central incisor with the natural tooth in the left central incisor. So we did all the initial planning, conventional planning, but supported by a digital smile design that was like a 2D planning, because we were using only a couple of photographs and a Keynote or PowerPoint software to do it. And then we did the final prep, the final impression. We tried to obviously to to modulate this gingival contour during 3 or 4 months to improve this anatomy. And at the end, we did a final impression, a conventional final impression, where you can see here. And then the lab technician changed this to a digital workflow, scanning the conventional model and doing and designing a zirconia abutment, as you can see here. This is a zirconia abutment with a specific anatomic form that was trying to copy our preparation. So you can see here the design. This is a zirconia piece that will be milled, and then after finishing this step, we did, or our ceramist did, a layering over the zirconia, so it could equal the final preparation in the natural tooth to its design in the implant. And over this, it built 2 traditional feldspathic veneers with a refractory technique, as we saw in the previous case. And this is the final result that we could achieve. So here we add some digital steps in the working process, but even still now we were doing mainly all the steps based on conventional workflow. Okay, this is the final result, where you can see the optical integration between tooth and implant, and I think it was a fair, good result. But again, all this is very based in, obviously the clinical work has to be good, but the technician is decisive in this final result. So this is what we are doing now, getting to what we call the biomimetic, adhesive, and ultra-conservative approach. This is our primary goal. And not in all cases we can do this approach, but we are trying to preserve as much as we can of the natural sound structure to come from these initial situations like this, where you can see lots of tooth decay, lots of old restorations, previous crowns, to these final results where you can see that we try to be as conservative as we can, and also trying to be biomimetic. I mean, when we refer to biomimetics, we were trying to get a final result that copies exactly the natural tooth, but not only in the optical aspect, in the anatomy, but also in the biologic and mechanical behavior in the long term. Okay, so in cases like this, again, we were trying to introduce a biomimetic approach, but at this time, we still were not very comfortable with what we have today, the digital tools that we have today. First of all, we have to say that in this kind of cases, we know now that even we don't have clear evidence of what is the best material or treatment strategy to apply in a case like this. It seems that conservative approaches are promising, because even they don't necessarily last longer than a conventional crown approach that we could introduce in this case. We know that when we get to the time that we have to repeat this kind of treatment to retreat these restorations, we will be sure that this remaining tooth structure will be more than enough to retreat and we will have this natural dentition for several years. At this time, again, we were doing this almost full conventional. I mean, as you can see here, this is a beautiful work by Miss Yolanda Cayero that works with us in Barcelona. And as you can see, this is a very beautiful manual conventional wax up. And again, as you can see here, this wax up is also, it's very beautiful when we try this in mouth to check the occlusion, the aesthetics, and our final objective. When we change this to the final restorations, and in this case we use what we call the sandwich technique, or the three-step technique that was described by Dr. Vailati a few years ago. Although she published that paper directed for patients with erosion, not specifically for bruxism patients. But as you can see, this is very conservative, doing this kind of approach where we don't do a full tooth preparation, but more than that, we do vestibular and palatal veneers. In this case, the first phase that we did was to introduce the new anterior guidance and the new occlusal plan. As you can see here, we did some preps in the posterior, including the vestibular wall of these molar and premolars because of the aesthetic involvement, and we did the palatal veneers using, in this case, monolithic restorations with lithium disilicate, as you can see here in the model. And then we did conventional adhesive cementation. They are just stained, and this is a big difference from the previous cases where you don't have any kind of layering with the feldspatic ceramic. So we did the adhesive cementation using most of the times we use like our rubber dam, and then we go straight to the lower arch where we define the final DVO, the vertical dimension of occlusion, and we did it with bonded restorations. In the posterior teeth, we did like overlays, and in the anterior, we did like conventional veneers. And again, we did this with, in this case, monolithic veneers. You can see here all the steps. I go a little bit quick because we only have 1 hour for my presentation. As you can see here, the final restorations, monolithic again, stain, and then the final cementation. And you can see that the final result is obtained with the vestibular veneers, where in this case we did some layering. Here you can see the final preparations. I go quick so you can see all the contents of the presentation, and you can see here the aspect of the final veneers. And after cementation, you can see where we started and where we finished now. Where it's very important, of course, to refine the final occlusal adjustments, and you can see where we started and when we finished. So this is a very challenging type of cases, and as I said before, when we started to use these new materials that we are applying in the CAD/CAM workflow in the lab, so we were able to use monolithic restorations only stain or combined with some veneering. For that, we have several glass ceramics options. If you want to do bonded restorations, I remember that if you are trying to use zirconia, zirconia itself, it's not a very suitable material for an excellent adhesion. You can do some adhesion with zirconia, but you cannot do overlays or veneers with zirconia. So, but you have lots of materials that we are using nowadays. If you want resin composites, reinforced resin composites, I'm not a big fan, but it's a very good option for some cases, or all the glass ceramics options conventional or reinforced. So now you have feldspathic ceramics that are prefabricated, and you will have only to mill them and to stain if you want, and to polish them, or reinforced glass ceramics options like Leucit, like Empress from Ivoclar, or lithium disilicate, that we have several options from GC, Ivoclar, or Vita. Okay, so this is the kind of materials that you'll have to use if you want to go on a full digital type of workflow. Obviously, there are some issues or some questions open concerning the wear resistance. If you are more fan of a less wear resistant material, if you want to apply it in patients with bruxism. If you want a more rigid material like a lithium disilicate, and of course you have to be aware of the optical integration that each material will achieve. On our experience, every material are getting very more and more similar between them concerning the optical integration that they allow. For example, if you want to do, you can do with lithium disilicate, you can do a very beautiful restorations, and that's a thing that you couldn't do 10 years ago probably. Or the same with zirconia. You can do nowadays beautiful crowns or anterior and posterior with a monolithic zirconia that you weren't able to do it 10 or 15 years ago with the types of zirconia that we had available. But again, as you can see here, this is another case where we treated a patient with that did an orthodontic treatment. She had a problem of she had a very severe tooth abrasion, as you can see here, and she needed a full mouth treatment. And you can see here this is a conventional mock-up that we did, and we applied again a three-step technique where we applied for the first time resin composite milled without staining. In this case, it was our first case, and this was a little bit the beginning of the use. This is the Lava Ultimate restorations, the palatal veneers and the posterior overlays. You can see here how the evolution of the case. And the lower arch, we did some overlays in the second molars with the injected lithium disilicate, zirconia, monolithic crowns, and in the anterior inferior dentition we did feldspathic veneers, conventional refractory feldspathic veneers, and at the end the vestibular upper feldspathic veneers for the final aesthetics. But again, all this combining most of the treatment with the conventional layering technique. Okay, so this is the initial and the final result. So in the last years, we tried to change it. We tried to improve what we were planning and the transition to the final result, because we are not happy with some changes that we assisted when we did a conventional mock-up or wax up and the design of the final result, because in most of the cases it was not possible to copy exactly the same anatomy. We could be close, but it was not the same thing. And on the otherwise, we were always, as I said before, converting a conventional impression and a model to a digital workflow when the lab was building using CAD/CAM technology for the infrastructure, or even for the monolithic restorations. And concerning that, when we talk about conventional impression, conventional impressions, they are part of our daily clinical practice, and we still are doing them. But it's important to remember that we have still some issues with this kind of impression. First of all, because and the principal issue that I can detect is that many mistakes, we only detect them only in the lab, and there's things or issues related with the patient's acceptation of this kind of impressions, but it is still the gold standard. We are trying to change it, but it's still the gold standard. And then when we obtain the gypsum model, it's a very sensitive procedure, because many mistakes we can observe or in the impression or when we obtain the final model. So we can say that the accuracy of the final model is mainly a sum of small mistakes that we are having in all these traditional workflows. And that's why we try more and more to eliminate this step and to substitute it for the intraoral optical scanner. Obviously, until some years ago, it was not possible to use it because they didn't have enough quality, and mainly because they had a forbidden price. They were too expensive. And in the last years, many manufacturers launched to the market several models of intraoral scanners that are I think every 2 years are getting updated by the hardware or even only by the software. And the most of them use the more or less the same technology with they are based in a projection of a laser or light over the object, and they identify the anatomy or topography of this object, and they translate that to an STL archive. So they are available for teeth, implants, orthodontics, surgical planning, or any other kind of restorative procedures, as you all know. So I'm not reviewing the features of the actual intraoral scanners that you can find in the market. I'm sure that lots of you are now using in your daily practice, and probably for example, I have my scanner is 3 years old or 4 years old, and I think I have to change it now for a new model. And it's something that it's already a part of our daily practice. It's nothing that we are not still trying. We are using it in every day. So I can say that 80 to 90% of my impressions are made with an intraoral scanner. I'm not going into the comparison between different models. You have multiple options in the market. A very wide range of prices as well, and but I think I can say that 5, 6, 7 brands in the market that are really reliable, either in natural tooth and also in dental implants. But you have to be aware of what are the actual limitations of this kind of devices. Some features like quality control in real time are very important, because we can nowadays control at the moment the quality of our preparations, the quality of the impression. You can change some finishing line at the moment and rescan only that area. You can compare the pre-preparation and post-preparation. You can do the comparison to check, for example, the restorative space that you're leaving to the lab. You can do all the steps to go on to the occlusal records with some limitations, it's true, but you can do it's more and more getting more and more reliable. And of course, for orthodontic planning, for surgical implant planning, they are mandatory in nowadays. So you can, new features are going out into the market that you can scan even conventional occlusal records. You can do high definition scanning of certain areas, and you can merge impression scanning between two different moments of the same case, and of course conventional impression with a digital impression, and you can merge both. So the intraoral scanner is I think it's a mandatory now in our clinic, because it has improved the impression procedure. It has improved the quality of our impressions. It has improved as well, and this is important, the patient attention. The patient loves that we use this kind of technological devices, and they like it, and it's more comfortable for that. And to reduce time, and this is very important, I think really that we reduce time using an intraoral scanner because we reduce as well the number of steps. This is the traditional STL file that will be created with intraoral scanner. I will not go into this technical future, but I will tell you some limitations that you still have with this kind of scanner. First of all, there are objects with high translucency, like braces, metal devices, metal restorations. It still has some issues when scanning these kind of objects. The problem, I think, is still when we are dealing with full arch situations, when you are preparing 12 teeth, when you have to do full mouth impression with more than 3 implants. And when you have bloody field, or lots of saliva, or infragingival margins, we are still struggling with some limitation. That's why in some cases, I'm still doing both impressions, the digital and the conventional impression, because we are not still satisfied with the capacities of the actual scanners that are in the market. And this is very important for you to know, that we are still dealing with some issues. And in some cases like this that you see here, we are doing both workflows. This is a case that I won't go too much to the diagnostic of the diagnosis of this case, but you can see we have 2 old crowns with an invasion of the biological space, where we had to improve the proportions of the central incisors and the laterals as well, because as you can see, we had lots of asymmetry even in the gingival margins between the canines and the centrals. We did this is the initial X-ray. We did an initial conventional 2D planning, and in this case we did an initial intraoral scanning. This is very quick. You can nowadays last not more than 1-2 minutes to do this. So you can see here the old procedure. This is a Kestrem CS 3600 that it's our scanner nowadays. Now it is upgraded its software. As you can see, it's very easy to do it. And then you can see here you have the ExoCAD software that will help us with the digital planning. But in the same way, we did a conventional workflow in all the procedure to compare, because at this point we still had some doubts of which procedure, which workflow could be more reliable. So you can see here, this is common for digital or conventional workflow. We had to do this additive mockup. As you can see, this is the mockup that we did. As you can see here, we improved the proportions and the balance between the 4 incisors and the canines. And you can see here the first provisionals, the removal of the whole metal ceramic crowns. We did some crown lengthening to improve the distance to the biological width, like as you can see here. I'll go quick with this. It was a minimal invasive procedure using this kind of burrs to remodulate and relocate the osseous crest, as you can see here. So we restituted a good distance from the margins to the final, to the osseous crest, and then we did the buildup of the two central incisors, and we did a vertical prep procedure. That has, in our opinion, some advantages in this kind of cases. We did the polishing, we did the relining of the provisional, and we waited for 3 months approximately to do the final impression. In the same way, we did a very conservative preparations in the two lateral incisors to improve the proportions between the width between the laterals and centrals, as you can see here, with conventional chamfer in the equigingival margin, as you can see here, the final polishing. And again, in this case, in this kind of technique, we should always copy the emergency profile of the provisionals. And until now, we were doing this in a conventional way with a conventional impression. In the same way, we did a digital impression, as you can see here. So we had both models, a physical one, a digital one, and then we could merge it in the lab. And as you can see here, we are scanning the provisional, so we can adapt it independently of having a conventional emergence profile copy. So you can see here as well the scanning of the provisionals in mouth. So, and this is the HeLab technique that we use to facilitate the information that we send to the lab, so you can before sending us the restorations, you can compare with this protocol the value and the chroma of the final restorations. And we did both workflows in the lab. So we did one workflow full digital, as you can see here, the design of the restorations. This will be totally monolithic and stained, and then you can see here a conventional layering technique where we did the feldspatic layering, that we know that we can get more individualized restorations. But as you can see, the comparison between CAD/CAM manufacturing and handmade manufacturing, there's no such big differences nowadays, as you can see. And at the end, we mix, just to resume the case, we mix the two centrals handmade and two laterals with the CAD/CAM technique. This is the final adhesive cementation of the 4 restorations. I will go quick in this with the steps, all the prep of a glass ceramic that we use. And of course, treating the natural teeth with the protocol described several years ago by Pascal Magne, and then the final polishing that you can see here. And this is the final result. This was a beautiful work made by Dr. Paulo Ribeiro that works with us, and with a technician, Mr. Pedro Brito. So you can see here the HeLab comparison and the final result, the initial and the final result of this case. So, and in this case, we're merging both protocols. Things that we were getting in our daily practice, and that we saw published recently, was the issues that we still have with the intraoral scanner. First of all, not only the preps, the geometric form of our preps are suitable for getting scanned. The most difficult problems to solve that we are dealing with is that clearly the subgingival margins, where we are trying to use a more retraction, more aggressive retraction methods to open more the sulcus and to retract a little bit more the gingival margin. And the fluid control is I think the most delicate areas where we have to be careful with the intraoral scanner. That's why in a vertical prep we still have some problems to do these full digital. And of course, I remember that if you are dealing with a full arch treatment, I wouldn't trust completely in an intraoral scanner as they work now today. I think in the next couple of years that will be solved, but for now we still have some problems. And then are we able now to do full digital workflows without conventional impression? I think so. I think we can do it. And now I present you just this case to show you how are we doing this today. So this is a case that is not treated for now. We're still at the beginning, but I wanted to show you what is our protocol now. So we can use a couple of photographs, very simple photographs that we use for the DSD 2D planning, and we use an intraoral scanner. But at the beginning, you can use a software like the Smile Cloud that you are available, or the Smile Creator. And as you can see here, this is a very easy way to do it for the initial design to show the patient, but most of all to communicate between all the team elements and to start your real wax up 3D digital wax up, because as you can see here, we are doing all the digital 2D planning for now. So this is a very quick procedure. You won't last more than 5 minutes. This uses, as they say, an artificial intelligence algorithm. So we will just define some features in the photographs, and then we will be presented with some propositions of different natural tooth libraries that we will be able to choose. But as you can see, the software will present you from the beginning the most suitable libraries that the algorithm calculates to be more suitable for this case. And then you can change individually each tooth, and of course you can change the color, translucency, so you can do some modifications, and at the end, in a very quick way, you can show this to the patient, and the patient will be, I think, in my opinion, very motivated. Then we will go to the back office again, and this is the transposition of the initial planning to an open source software. You can use, this is a mesh mixer, but you can use it with the Exocad or any other design software that will allow you to do the 3D wax up. You can do it in your clinic. You can do it of course, with your lab technician. And as you can see here, we did the initial software planning based on this couple of photographs. So this is what we show to the patient. The patient obviously will participate in this initial decision. As well, you will motivate him, because this is a good change, and most of all, it's a very natural change that the patient will feel that it will be possible to achieve. And so from now on, we are doing these kind of treatments in the anterior upper dentition with trying to do most of our cases with this kind of protocols, doing what we call the full digital workflow. This was one of our first cases that we did, as you can see here. With the same kind of photographs, we did the initial intraoral scanning. The Mr. Waldo Zarco, that is an excellent dental lab technician, especially working with the Exocad software, did us this initial wax up. As you can see here, this patient did an orthodontic treatment. She had to correct this disharmony between the two central incisor and the left upper lateral incisor. You can see here. And then I didn't go into the 3D printing, but this is something that is 4 years ago. We were dealing with 3D printers, very expensive, very slow in printing high quality models. And now I just bought last week for our clinic 250 euro printer that I will show you the high quality that model that she can give us with in a 2-hour period. Okay, the printing time. So this is one of our first models made with this kind of printers. This is our conventional preparation. In this case, we were more aggressive because we remove all the old fillings, the class 4 composite, resin composite fillings, as you can see, and then we rescan the preparations only. We use the original archive. We did our conventional procedures, and then, as you can see here, Waldo will superimpose the original model with the new model with the preparations, and the software will merge the initial and the final model, so it will be easy for him to design the final restorations using exactly the same wax up design. The only thing he has to do now is basically to select, to adapt to the margins, and to select the material that we want to use for the milling. And in this case, as you can see, very thin 0.2 veneers. In this case, we used Empress, these lucid veneers, monolithic, that has some layering. You can see here these blocks are very nice to use them in this kind of cases. Obviously not for a single unit veneer, but as you can see here, this is much more close than we can say that is quite natural as a good integration. This is only with a little bit of staining and polishing. Okay, so this is the before the cementation. You can see here all the procedure of preparation of the glass ceramic veneers, and of course the natural tooth as well, and all the sequence of the cementation. I'll go quick because I'm only I will use 5 minutes if I may. So you can see here the final polishing, and this is the final result just after removing the rubber dam, and after 2 weeks you can see here the final result. And I think that we have a good integration. I say that if you want to do only a central incisor, maybe this is not the most appropriate technique. But if you are using in this case two central incisor from canine to canine, I think it's an excellent way of doing it. And as you can see, we have a good integration of our restorations. This is after 1 year, as you can see here. You can see some staining maybe in this area here in the interface cementation. So when we use this kind of workflow, full digital workflow, first of all, I think the main advantage is the digital predictability that we may find in this kind of workflow, because it uses, first of all, natural tooth anatomy libraries. The libraries, the tooth models that we're using are very natural, and we can copy them in the Waxam and to use them, the same exact model, to design the final restorations. The motivational mock-up that we do in this kind of cases, I think it might be excellent for the patient, and the similarity between the final restoration and the digital wax-up are very high. So this is I think it's one of the main advantages of using this kind of technique. So this is one of the first cases that we did as well, using the skin concept that was I think you've heard of it for sure. So you can see here that this was a patient who was not happy with this white stains. He had some abrasion as well. So we did an additive wax up, full digital. We did an initial scanning. We did the wax up and we tested it with an additive mock-up. As you can see here, in this phase, we know already how many that we'll have to gain from the tooth. It is more accurate to calculate how the thickness of the preparation that you will have to use, and you can do this during the preparation, so you can check exactly how much thickness are you getting to the lab. This is the printing of the wax up. As you can see, this is the motivational mock-up that you can do. And from now on, you do the conventional preparation guided by the mock-up, as you can see here, trying to be as conservative as you are able. And then you can see here the final result. These restorations are only milled and with a little bit of external staining. This is the result after 3 years. As you can see here, they are really nice for now. They are stable, and this is feldspathic ceramic. This is a Trilux blocks that we use. As you can see, we are dealing with 10 upper and 8 lower veneers. So this is I think for these kind of cases, I think this is the best option that you can use nowadays, because as I said before, I think you can get more and more predictable. So as a conclusion, and I think I respected almost 60 minutes of presentation, I think this digital workflow is getting more and more predictable with this new kind of advances. And even I think the most important issue that we have nowadays are the digital records, occlusal records. And I think in the next couple of years, we already have in the market, but we'll have more good devices with fair prices, because nowadays I think they are still a little bit expensive. Digital impression is clearly more demanding in terms of fluid control, bleeding, and in cases of deep marginal preps. I don't know if you agree with this, but it's my experience. I think there are some scientific evidence of this aspect, and I think everybody is having and feeling the same problem. So in some cases, it is simply not possible to do an intraoral scanning because it's not suitable for these cases. Concerning dental implants, just to remember that more than 3 implants, there's less accuracy than a desktop scanner. So we know that more than 3 implants, it's still tricky to get. We are struggling with the accuracy of these impressions, and of course, more in vivo studies are needed with this kind of full digital workflow. So we can be sure that we are getting a final, beautiful, mechanical, and biological good result. So I thank you a lot for this hour that you were there assisting, and I will be available from now to answer all your questions if there are any, and all your doubts, and thank you very much again for being there, and hope to see you soon, if not by Zoom. It would be preferable to be physically because I miss the real congresses and the real courses, where we can be physically talking to each other. Okay, thank you very much. I'm not sure if you have any question, any doubt. Okay, if there's no questions, I will give the word to Mario. He will present you a final video. And just I want you to say thank you again to KLOCKNER, to Mario and International Meeting Company, and hope to see you soon. Okay, bye-bye.